meeting.
Good.
I
just wanted to say, sorry, I should have introduced you at the beginning of the session, that you are the new group started just 2 days ago from Helen Joseph Hospital. You are rotating through Discoverers CHC, and you're going to be with us for 2 months. So you're going to join the discussions every Wednesday, and I hope it's going to be beneficial for you, and I hope you're going to enjoy it. So thank you very much for preparing in such a short notice the presentation, and let's listen. Welcome.
Thank you. Can you make me host, and then I'll be able to share my screen? Alternatively, I did email you the presentation, but if you are able to make me a combined host, I can share my screen.
Try, because Prof made me a host. We'll see how we can do it. It's Jennifer, eh?
It's Jennifer, yes.
Yeah, and you're presenting from the same computer with the other 2 doctors?
Yes.
Okay, so I need to make you host only you.
Yes, please.
Okay, let me try quickly.
Dr. Petkova?
Yes?
We are presenting second. The next presentation, may you also please make us a host. We are all
okay, what's your name?
It's Yerma van Veengaard.
Okay, we'll do that. Let them first do that, and then we'll just try now. Jennifer, please try.
All right. Can you see my screen?
Yes, we can see you. Super. Well, good. Yeah, please proceed.
All right. So we're going to start. Thank you so much. We're going to talk about HIV in children and focus on a primary healthcare approach. Here's just a brief overview of today's talk that we'll be running through in the next sort of half an hour.
Hello, everyone. I'm just going to quickly take you through the incidence and prevalence, mode of transmission, and early infant diagnosis. About 320,000 children under the age of 14 are living with HIV. About 12,000 children are infected daily in South Africa. However, these infections are largely preventable, and new infections rate has declined due to the success of prevention of mother-to-care transmission. About 80% of these infants born to women living with HIV, they receive virological tests within 2 months of birth. That's HIV PCR, which is being mostly done in most of our hospitals. Mother-to-child transmission rate, including the breastfeeding period, is about 4.6% currently. And currently our goal is elimination of mother-to-child transmission. With the modes of transmission, currently we have got 2 modes of transmission, with vertical transmission, the most common, which commonly occurs during pregnancy, that's in utero. It can also occur during labor or delivery, mostly with the normal vaginal delivery. We also have the transmission that occurs during breastfeeding period. In this period, we need to make sure that the mother's is virologically suppressed. We also have our horizontal transmission, which is the less common one, which mostly it can occur in adolescents through sexual abuse or other causes. The early infant diagnosis, testing for HIV, it must be done with appropriate counseling of the caregiver and the child. So from birth to 18 months of age, we do the HIV PCR, which needs to be confirmed by the second confirmatory PCR test. After 18 months of age, we do the HIV rapid or ELISA, which also need to be confirmed with the second rapid or the ELISA test. So we do the PCR or the HIV testing in different stages. So we do it at birth. We also do it at 10 weeks of age, at 6 months. So we also need to make sure that we do the age appropriate testing, that's 6 weeks post cessation of breastfeeding, depending on whether the infant is less than 18 months or more than 18 months. So you also need to retest at any age if the infant or the child is symptomatic at admission.
All right, and then I'm quickly going to chat about the baseline evaluation prior to the initiation of ART. So it's important to establish a definitive HIV diagnosis and to do the WHO staging. Then we need to establish the CD4, and in children we use the percent as long as they are younger than 5 years old. It's important to exclude TB and to ask about TB contacts, to screen for and treat opportunistic infections first, to identify a responsible caregiver to administer the treatment, to counsel and educate both the caregiver and the family, and then to discuss disclosure, which is an age-appropriate matter. Next, I'm going to run through the first-line regimens in children living with HIV. So here's a really nice overview of the different age categories and weight categories, and I'll go through each one. Starting with neonates that weigh more than 2.5 kgs but are less than 4 weeks old. So you're going to start with your confirmatory PCR, you're going to do a clinical examination, get the CD4%, then you're going to do an FBC, a DIF, and an ALT. And you'll consider genotype testing if the mother was failing second line or was already on third line. The ART regimen is nevirapine, AZT, and 3TC. And then just to note that it's important to seek expert advice if the infant weighs less than 2.5 kgs or is unwell, has TB, syphilis, or severe anemia. So after the age of 42 weeks of corrected gestational age, we can then switch the neonate over to ABC, 3TC, and lopinavir ritonavir. This switch does not require a viral load to make this switch. Next, in children that are weighing more than 20 kgs but are less than 10 years old, we can change the patient to dolutegravir. This switch does require a viral load, and preferably the child should be virologically suppressed when you switch to DTG. So your regimen there is going to be ABC, 3TC, and DTG. Moving on to children and adolescents that are more than 10 years old and more than 35 kgs, we can switch to tenofovir. So once again, this requires a viral load before you can switch, as well as measuring the creatinine clearance using the Conahan-Barrett formula. And I've put it there, and that clearance should be more than 80. So then you will switch them to the adult TLD. So it's tenofovir, 3TC, and dolutegravir. Briefly going over prophylaxis. So for children, anyone less than 1 year of age needs to be on Bactrim prophylaxis, regardless of CD4 and clinical stage. Then between the ages of 1 and 5 years old, if the CD4% is less than 25% or they are WHO 2, 3, and 4, then you'll start Bactrim. A child that has had PJP needs to be treated with Bactrim prophylaxis after the treatment for PJP has been completed. And then any child that's more than 5 years old will use the adult guidelines. So if their CD4 is less than 200. TB preventative therapy, any child, regardless of HIV status, that is less than 5 years old and has a close contact, needs to be on TB preventative therapy. Then a child that's between the age of 5 and 15 years but is HIV positive with a contact will also need TPT. I already spoke a bit about baseline bloods, but just to mention, everyone will need an HIV test, CD4, and FBC. A viral load in children is not required as a baseline blood test, but it might have prognostic value. Cholesterol and triglycerides are required if you're starting lopinavir, ritonavir, and creatinine if initiating tenofovir. We don't routinely do Hep B surface antigen in kids, and we also don't routinely do CLAT. Then your monitoring, it can be broken down into 3 levels. Firstly, determining the clinical response by looking at the weight, height, and head circumference, the neurodevelopment, screening for TB and other opportunistic infections, and doing the WHO staging. The viral load should be done 6 monthly if the child is less than 3 years old or more than 10, and then annually if the child is between 3 and 10 years old and is virologically suppressed. CD4 count or percent is needed 6 monthly with a high viral load, or if the child still qualifies for bacterium prophylaxis, but it's not routinely required in other scenarios. And then just to remember to always evaluate for side effects. So always ask about side effects, and depending on the regimen you're on, to do appropriate blood tests, which I put here on the slide. And then lastly, children with HIV are high risk of TB, and to remember that they can present atypically. So we need to have a high index of suspicion. Atazanova is not suitable to be taken with a rifampicin-based TB treatment. Lopinava, ritonava should be super boosted. So in adults, we usually just double the dose, but in children, you need to give them extra ritonava sachets. Then for dolutegravir, you can double the dose as same as adults. And just to be aware that these children are exposed to a very high pill burden. So it's important to simplify the regimens.
So when facing a child who presents with a high viral load, that being defined as greater than 50, we use our ABCDE to assess the reasons why. So A would be your adherence problems, B would be bugs or concurrent infections, C would be incorrect dosages, D, drug interactions, and the E is the second letter in resistance, that E. So to go into adherence problems, so it's a common issue faced with kids, and it can be due to side effects. Side effects differ based on the drugs patient may be on. Commonly, patients on abacavir may face hypersensitivity reactions. Patients on lamivudine, it's fairly rare, but they can experience a red cell aplasia. Patients on efavirenz usually have sleep disturbances, also can experience a rash, and has been seen where patients have developed gynecomastia. Patients on lopinavir or ritonavir very commonly experience GIT symptoms such as diarrhea and nausea. Like Jen mentioned earlier, we do lipid profiles because they also develop dyslipidemia. Patients on zidovudine can develop anemia and neutropenia as well. Tenofovir, we look out for renal dysfunction, hence we calculate the eGFR, and with that, patients can also develop osteopenia. And dolutegravir, it's common for them to have weight gain and insomnia. Another issue with adherence, very common with children, is they're very reliant on family structures for their medication. So reliance on elders, guardians, siblings to give them the medication. If they forget, then the child suffers. Another issue mentioned earlier is the high pill burden. A lot of these regimens, and because of the weights and so forth, may lead to the child having to consume multiple pills. It's very problematic and can lead to cooperation problems and poor adherence. Another issue is swallowing of tablets. We always try to switch from the liquid-based to the tablets because of taste, but some children do have difficulty, so it's important to assess that before you change. Stigma, still an issue in this day and age. Patients have fears about their status and having people know and won't want to be on treatment out of denial. Lack of understanding in terms of understanding the chronicity of the disease, the requirement of the treatment daily for life, and timing of treatment. If some patients are told at clinic they have to take it at 8 in the morning and 8 at night, and they feel that once they get to helpless aid, if they haven't, that they can't take it anymore. So it's important we stress that even if you're a bit late, it's always much better to take your medication rather than not. Lastly, lack of accessibility in terms of transport to clinics, funds to get there, food to have before you take your medication, and so forth. B, opportunistic and concurrent infections. As mentioned earlier, it's important to screen for TB at every visit, and also not just typical things, atypical pathogens. With TB, of course, meningitis and things like that. Not just the illness itself, but medication for the illness can affect your dosing. And then that leads to our third point, incorrect dosing. So dosages are based on age, weight, renal function. A lot of these meds are multiple combinations. Sometimes you have to switch children from liquid-based dosaging to tablet-based, and mistakes can occur. Children can be underdosed, and so that can lead to a higher viral loads. That also would go hand in hand with the next point being drug interactions. A lot of the medications children could be on could have effects with the with the ARV drug efficacy. We touched on double dosing earlier. It's important with TB because rifampicin has serious effects on the drugs such as dolutegravir, nevirapine, and lopinavir. Also important to note, children with comorbidities, their medication can affect it. Things like epilepsy, anticonvulsants have known to have an effect, and metformin as well. And then resistance, children exposed to multiple regimens with poor adherence and so forth, over time may develop resistance if they've been subtherapeutically dosed, and that could lead to high viral load. Then in terms of child-specific problems, so important thing we stress is in these clinics is disclosure. So around 5 to 6, we start with partial disclosure, explaining to children in more easier terms, germs and soldiers, Spider-Man and his enemies, things like that, to try and get them to understand what it is the medication does in terms of fighting off the illness, so that they understand the importance of taking it. And we try and reinforce this with parents to get them to ask the kid at each occasion why they're taking their meds, because their meds are Spider-Man fighting the bad guy, as an example. And then as they get older, we try and move on to full disclosure. So telling them that the illness and the germs and the bad guy is called HIV, and the meds are there to fight it, and giving them a better understanding of it. Other child-specific considerations to take into account when you have patients with high viral loads. The liquid formulations are generally can be poorly tolerated. We've tasted Calitra, it's horrible. And so for kids, it's not exactly something they want to take. There are some things you can try and do to improve the taste. You can coat the child's mouth with peanut butter. You can ask the mom to give some breast milk just before. Some parents give the child some ice or something cold to almost numb the mouth. But they are generally poorly tolerated, and we should always try and look for ways to improve that. The reliance on the caregiver, like we said before, so it's important that in all interactions we stress with the caregiver their need to be hands-on and focused, and to make sure the child gets their medication. And then emotional and psychological support. It's a chronic disease, it's very traumatic, has a lot of stigma in our society, so it's important that we find ways to support the family and the child in multiple facets to ensure that they adhere and they understand and they follow through with their medication. And then in terms of adolescence, it becomes a higher risk category. So we need to ensure effective transition, because they go from being seen in HIV child clinics to adult clinics, we need to stress on them the importance of their medication, the importance of their reproductive health, and using contraceptions and condoms and so forth. So when to refer patients, so if you see them at your primary healthcare facility, it's always important to go through your IMCI guidelines. If you note any danger signs, you should refer. Patients who are failing to thrive as per the WHO Z scores should be referred. Patients who screen positive with TB symptoms or meningitis should be referred to bigger facilities. We should also screen patients for mental health disorders, non-communicable diseases, and neurodevelopmental disorders. Patients with significant drug interactions, such as rifampicin, or on TB treatment possibly, should be referred. And definitely patients with virological failure who may require being changed to a second or third line treatment would need referral. Virological failure we define as a patient 3 occasions over 2 years, or viral load greater than 1,000 with clinical signs of immunological or clinical failure. And if there is failure resistance suspected and you suspect that the patient may need genotyping to assess for resistance, you should refer to a higher facility. These are some resources of numbers you can call if you're ever stuck and need more advice.
All right, and then lastly, we just put in all the different abbreviations because often it gets quite confusing when everyone's using all of these letters and these words. So this is just for your own reference in the future use of these drugs. All right, thanks.
Thanks to the team. It was a wonderful presentation. So any questions or comments? You can add something. I also want to add 2 things. In children, don't forget that any child at any age needs to start treatment, no matter how much is the CD4 count, viral load, or whatever. Or you do the staging. The staging is done because you need to be aware if you need to treat some comorbidities or opportunistic infections, not comorbidities, some opportunistic infections. But anyhow, you need to start the children as early as possible. So that requirement is to allow the child for longer life, to have a longer life with earlier start of treatment. The other thing is, which I wanted to say, is the HIV test that is done to the newborns at the facilities where the mother gives birth is also an important matter for the clinical governance. The stats are disastrous. Children get the test and the mother never comes back to make a follow-up on the test. The same reasons, either is the stigma or the mother gave another address, proof of address that just because she wanted to deliver in this clinic or that hospital, or just to skip the area that she lives in. So keep in your mind that is another big issue with in a clinical governance, with the make a follow-up on the children, of the babies, of the newborns who were done the HIV test and the mothers never did the trace of that result. So this is the 2 things I wanted to share with you. So any other questions or comments, you're welcome. We still got a few minutes left and to start with the other presentation. Michelle, if you want to add something.
Maggie, I think you said it all.
Okay, thank you. Just let me make the other intern a host. Okay, Irma,
Thank you.
can you
Dr.
share your
Peskova.
screen now?
Will
Can
do
you
so.
share your screen now?
Is it working?
Yes. Please proceed.